Well, good afternoon, and thank you for joining me tonight for this live webinar from OrthoVirginia. My name is Joshua Herzog. I am a spine surgeon in Richmond, Virginia with OrthoVirginia. I've been here for almost 7 years now in the Richmond area. OrthoVirginia is an orthopedic practice that has offices all across the state of Virginia, and I am located here in Richmond. I operate predominantly out of Johnston-Willis Hospital in Richmond, and tonight I just wanted to spend a few minutes talking about some enabling technologies or advanced technologies that are available for spine surgeons across the country, but here in Richmond as well. I think that when you talk about enabling technologies, and we're going to go through all these, it kind of means a lot of different things to a lot of people. Just real briefly, this is, again, just a brief slide about myself. I did train in the U.S. Army, was in the U.S. Army for a very long time, did my residency and my fellowship in spine surgery at Mass General, at the Harvard program, and then came out and continued to practice in the Army spine surgery. And then again, 2016, came here to Richmond. So in brief, I want to talk a little bit about how spine surgery is conducted. I want to talk about minimally invasive spine surgery versus open techniques. And then we're going to talk about some enabling technology or new technology that's available to us. So the spine in general is a very complex structure. It predominantly provides support for the torso and connects the arms and the legs. It has a bunch of things that surround it, to include predominantly the bony architecture, but the discs that live between it, ligaments that connect it. There's joints that are on the backside called facet joints. And then, of course, there's muscles and neural elements that are intertwined throughout the spine. For the most part, when I see patients in my clinic, there's a lot of conservative options that we kind of exhaust and go through. And most people, whether it's neck or back or thoracic spine, tend to improve with conservative measures. And so they're very, very successful. And we definitely try to exhaust all of those predominantly. But those patients that don't get better with conservative treatment, or have severe pain or weakness, or have instability or tumors or infections, those are patients that we think about doing some type of surgical intervention. And when I think about spine surgery and surgical intervention, I kind of think of two different baskets. And in general, we have kind of basket number one, which is this very broad term. It's a decompression type of a surgery. And those come in different forms, like laminectomy or microdiscectomy. But in short, it's really, we're trying to kind of get the pressure off the nerves where they're otherwise being compromised. And then the other basket is some type of fusion. And so when you do a fusion, you're oftentimes using some type of devices to hold the spine still while it fuses. And so this is a picture of a lumbar spine fusion, where we have some screws coming in the back of the spine on the right side, and then a little kind of cage that sits in the front. It kind of looks like a domino or a spacer. And through those devices, we get a fusion of the spine. So classically, how we used to do fusions in the 80s and 90s was kind of an open approach. And if you look at this graphic here on the bottom left, you can see that you have a large exposure, and you're kind of very open type technique where we're looking at the anatomy, and then we're instrumenting the spine, the screws or the cages, and then trying to hold the spine still with an open technique. And in the late 90s, early 2000s, a lot of surgeons have kind of migrated to more of a minimally invasive approach, or approach that is kind of muscle sparing or limiting the size of the incision or the dissection in order to put screws or cages into the spine. The MIS, or minimally invasive spine surgery, does have kind of a steep learning curve, and there's a lot of people have trained in this type of surgery and are very competent with it. And as we go through and as we learn about this minimally invasive spine surgery, kind of the thought process is that we're doing less dissection, so we can have a faster recovery for our patients. We can have less pain post-operatively, and a faster healing for those patients because we're not doing as large of a dissection. And classically, when we look at the literature or the information or the science, a lot of studies that have come out are kind of descriptive in nature, where we kind of say, well, looking back at this, these patients have done well because of this or because of that. And I think where research and where, really the surgery is going is trying to create something that's more prescriptive, that something like where we could say, hey, I intend to do this, and because I'm doing this reproducibly, like I'm going to create this outcome. And so, I think in the world of spine especially, there's a lot of room for improvement in that. It's like, we want to create a situation where I can look at a patient and say, I plan to do this, and your outcome is expected to be this. And I think that some of these enabling technologies are helping us do this better with minimally invasive spine surgery. So I know that when people think about the OR, at least before I got in the OR, when I was a young man kind of coming into medicine, I always thought, it's the patient and the doctor. But in reality, it's a whole slew of people behind the scenes that are working endlessly to make that surgery happen. It's much like this presentation today. So, there's a lot of people behind the scenes working to make this happen. And so you're not seeing them on the film, but shout out to Margaret, who's doing the IT stuff in the background for me today. She's working very hard. So I'm just saying in the OR, it's very similar to that. And so we have a slew of people that are in the room that are making the magic happen. And some of those people are scrub techs, anesthesia providers, certified registered nurse anesthetists, physician assistants, surgical assistants, vendors or representatives from companies helping run machines, the fluoroscopy technician, the robot technicians. There's all these people that are helping. And so I just wanted to real quick show you, like, without all these people, I would not have the same outcomes for my patients. And so it's a huge slew of people. And we're going to talk about some of those people and some of that equipment that I'm using in the OR to make these outcomes more predictable for my patients. So enabling technology really is any planning software, computer-assisted navigation, intraoperative three-dimensioning, or robotic system that we're using in the OR, usually to place instrumentation or screws, but that's changing rapidly as well, to create a fusion for a patient. So the first one is and very straightforward. I think most people kind of expect that we're using some type of imaging. Most of these screws are going into bony prominences or places in the spine, and the most basic of which is an X-ray. And so you can do spine surgery without X-rays, but for sure X-rays been around for a long time and readily available in most operating rooms. You can shoot a plain film radiograph and get almost an instantaneous read on what that radiograph looks like. And that's shown on the left side of the slide there. The second piece of equipment that we're kind of using, and again, has been around since the mid to late 90s, is fluoroscopy. And so this is a live X-ray. You can get usually biplanar or different imaging rapidly, like a straight-on film or a lateral or a side film, and you can get the immediate picture on the screen in a digital format. And that's called fluoroscopy. And so we use those to put instrumentation in almost all the time as well. And then the other one is this 3D imaging. And so this is called an O-arm, but it's a 3D imaging. This is made by Medtronic, this device here that I'm showing on the bottom right. And this is a three-dimensional image of the spine in the operator. So this is a way to look at essentially like a CAT scan in the OR. It's a mobile CAT scan, but it's a three-dimensional picture of the bony anatomy. And these O-arms are three-dimensional imaging devices, come in all different varieties, and there's a number of different manufacturers. Those three-dimensional imaging devices can be used while you're putting the screws in or after you put the screws in to verify it. They can be used in conjunction with this next technique, which is called navigation. So navigating the spine is simply when you have a three-dimensional image of the spine, you can use navigation to guide where the screws or cages are going. And this is a live feedback. So you'll have a biplanar view of the spine like we're seeing there in the picture. So you'll have a cross section and then a lateral film or lateral sectional or sagittal section of the spine to look at exactly where those screws or cages are being placed real time in the spine. And as you move your hand around, you'll actually see those screws move, and then you can put it exactly where you want it to be. And so this again is a picture of that navigation. And so as that navigation goes through, you can see all the different instrumentation that's actually available there on the left side. So these are things like pedicle finders, or which is the guide, a probe down where the screw is supposed to be, maybe a ball tip feeler, or again, you can like a probe to kind of feel and explore where you think that instrumentation is supposed to be. And then even a screwdriver, like that's navigated to then put the instrumentation exactly where it needs to be. And so that's all navigated spine surgery. And there's a number of different navigational instruments that are available for use in spine surgery. And so the most popular is Medtronic Stealth. It's been around for the longest, and then other companies now have come out with similar navigatable instrumentation sets. So when we take that then to the next level, if you were taking a navigated screw or a screw and placing it in space and watching on a screen where that was being put into the spine, you can take the next step, which is a robotically inserted screw. And so for this, the robot actually, you have a preoperative CT scan that has a planning opportunity for you where you can place the instruments exactly in the spine where you want them to go. And then tell your robot that this is where I want the screws to go. You sync up the robot and tell the robot to go to a certain position, and the robotic arm moves into that trajectory. And then you verify with fluoroscopy or anatomical landmarks, and then you place the instrumentation where it's supposed to go. So there's less freehand mobility, but the robot knows where the pedicles are or where the inner body is supposed to be, and then it's placed in that position appropriately. So this is again a picture on that left side of that robotic arm as we're putting a screw through it into the pedicle. And you can see the robotic arm on the right side is kind of out in space with the computer monitor showing where that robotic arm is on target or on trajectory to place the screw. The Mazor Renaissance and Mazor X are now owned by Medtronic as well, are some of the oldest systems on the market, but there are other companies now that have robotic arms that are active or passive as well, and these are available on the market. But again, the idea here is that arm is moving through space based upon a predefined position that you have defined on your preoperative planning software to put some type of instrument into the spine. So as this digital spine has evolved and as it's gone through, as we look at X-rays and then CTs and MRIs and then fluoro-based navigation in the 1990s and CT-based navigation, which is the first one again was the Stealth, and then O-arm navigation, which is the Intraoperative 3D imaging. Now we're into a realm, and then robotics, as we talked about. Now we're into a realm of some augmented reality, and so you're taking the reality that we're perceiving and augmenting it somehow with almost like a video game to instrument the spine. And so this is something that is relatively newer to the scene for sure, but this is an augmented reality display that we're kind of looking at here called HOLO. And this device here, you have a screen that you're looking through, and the spine is projected. A cartoon rendition of the spine is projected directly onto the real spine in its location. And you can take then an instrument and place it into that projected spine, and therefore instrument the real spine in the same fashion. And this can be done in an open technique or an MIS technique or even a small incision percutaneous technique. And so the setup for this would be very similar to the fluoroscopy or the robotic system. And so we have the AR display with the surgeon on the opposite side, and then you have the controller workstation where the engineer is running that workstation to make sure we're on target. The surgeon is wearing some very lightweight glasses and then instrumenting the spine through this AR display. The beauty of this, the HOLO system is not only is it augmented reality, but it's also artificial intelligence. So now we have a system where the computer is doing some planning for us that I am then overseeing as a surgeon. And so we can have this artificial intelligence where it takes the spine and it'll actually segment it up and define it where it is, not only in space, but what the different particles of the spine are. So that includes like the front part of the spine called the vertebral body, or the pillars of the spine called the pedicles, the wings of the spine called transverse processes. So it'll auto segment the spine and put it all out there, and then render a 3D image of that, and then project that onto the real spine. So once it segments it again, it'll render the 3D image and then project that on there. But very, very intelligent piece of software here that can take that 3D spin and then segment it up into different particles. So then I can decide which piece of that spine I want to instrument. And the colors are very, very helpful in the OR, because unlike the cartoon pictures, the spine is not different colors otherwise. So the AI software also in this HOLO system not only segments the spine, but then it actually goes through and plans some screw trajectories. So this is also unique, because whereas I, the surgeon, before would independently plan my screws and then okay them, now I can have the AI software plan the screws, and I can oversee it and say, I like that trajectory. I think where you're putting that is correct. But it's not just me in the OR doing it. I always say, it's good to have another set of eyes. And again, these are all just layers of safety, right? So whether you talk about fluoroscopy, 3D imaging, navigation, or robotics, they are literally just another layer of safety for me in my operating room and for the patient to get a better outcome. So once that AI software has overlaid and segmented and then plan the screws, I can okay it, and then it's going to overlay the 3D anatomical model onto the real spine, and then you're going to instrument the screws, replace the cage as needed. And you do that through some instruments that are navigated but show up through the screen. So very similar, like to the Tesla, which is this program. So the Tesla system has an AI segmentation, this artificial intelligence, where it can actually look at a screen using some machine vision and identify this is not part of the road. This is an obstruction. And so it's kind of lay it out and lay it green. This is a danger area. So the same thing happens with the HOLO. So it segments up the spine and then comes up with it. The same thing with the Tesla, like in your drive, you say, I want to go to this point. It's going to autonomously plan that navigational route. It's the same thing for these screws. So there's some autonomous planning that happens where the screws go. But if I want to detour or change, I can still change that detour, but it's doing some thinking for me. And then likewise, it can then guide the trajectory. And so, this is where you want to be, this is where you should be, and then give you some real feedback to where you are and if it likes where you're going and if you're on target. So that's in summary what these enabling technologies can do for you. That was a very, very brief overview, but you can see there's a slew, and I think there's lots more to come. But I'm proud to say at Johnston-Willis Hospital in Richmond, they've had the 3D Medtronic O-arm for a very long time. They've had navigation available for a very long time, over a decade, and have, with both those, a plethora of experience and ability to use those. The Mazor has been there since 2016, very early with the Mazor, and still very vital to my practice. And the Stealth Robotics, which is a combination of navigation and robotics, has been there since 2018. So we're integrating those two technologies together there. And then the technology has been there just recently, just a brand new addition. So again, showing the commitment that OrthoVirginia, Johnston-Willis have to bringing technology to the OR to improve these outcomes for these MIS surgeries. I think that when we look at this, it's like, where are the layers of safety? And that's really what it boils down to. It's like, how can we be the safest in implementing surgeries, not just here in Richmond, but really across the country? And there are just layers of layers. And so, I mean, of course, the primary layer, and I always say, the buck stops with me, but it is the surgeon. And so the surgeon decides ultimately, like I would, obviously feel very nervous about fully releasing this, to any robot or, navigational system. But of course, there's tons of oversight, and it's like, I think about it like a lot of times, like flying an airplane, like the pilot's always there, but lots of help, in the background to make sure that we're getting to the location and getting to the point that our patients need us to be at. And so the surgeon's critical. And then I think that for sure there's a lot of preoperative planning. And so like showing up to the OR without a solid plan is always not a good idea. And so there's lots of software that we can use to kind of preoperatively plan to say, we're going to do this, and not only are we going to do this, but we're going to use this cage with this size at this location with this lordosis and this amount of balance. And then in the back, we're going to create a rod that then creates, that lordosis for us. And then live X-ray, which is the fluoroscopy, navigation we talked about, robotic assistant, the AI, artificial intelligence, helping me segment and auto plan some screw trajectories, and then augmented reality to overlay that cartoonist spine onto the real spine, I think are all big factors in patient safety. So, I mean, in conclusion, most patients get better, I think, with conservative care. They don't need to go to the OR, and not everybody needs a fusion. So, I mean, there's lots of surgeries where we just do some decompression. But, if we are going to do a fusion or put screws in the spine or cages in the spine to get a fusion, I think enabling technologies, especially if we're going to do an MIS type surgery where the visualization is not as good, these enabling technologies help us to better visualize the spine through advanced imaging or navigation, robotics, or augmented reality. And so thank you guys for having me. I really appreciate it. Anytime I can talk about the spine, I'm happy to do so. It's a pretty complex organ, and still loving what I'm doing. So thank you very, very much. I'm happy to answer some questions if we have some, or talk about my kids. I do that too.
Thank you so much, Dr. Herzog. We do have some questions. Our first question is, does it take longer than a traditional surgery to use this additional technology?
Yeah, I think the learning curve obviously is very steep. And by that, I mean, like in the first few cases, it's going to take longer than a traditional surgery. I think that's true. I think that the way that you apply it, or the way that you roll out any of these new technologies, you have to be very careful as a surgeon to do them appropriately. So lots of preoperative planning, lots of cadaver labs, lots of sandboarding, or in the Army, what we used to call it, role playing, where you're like laying out, these are the steps we're going to follow to get us there. And ultimately, I think that it's always a give and take. So it's like, okay, if the surgery takes a few extra minutes, but I'm getting a higher safety protocol and I'm getting better outcomes, then we're in a good spot, But if the surgery is doubled in length and we're getting the same outcomes, then that's not acceptable. And so I think there's always being very, very careful to not squander those OR minutes is really critical for my patients.
Thank you. Can you please explain again what MIS surgery means? You had it on one of your slides.
So MIS is an acronym. It stands for minimally invasive surgery. And so it really means like muscle sparing. So whereas classically we used to do a large incision and look at all the anatomy and make sure we fully understood exactly where the pedicles were, now we're trying to make a more limited incision. But with that the benefit of the limited incision is that there's less dissection, less trauma to the soft tissues, a more rapid recovery, less blood loss for the patients. But the trade-off is the visualization is not always as good with an MIS surgery, because by default, you're not seeing as much of the spine as you would with a traditional open approach. And so the idea is that with some of these enabling technologies, we can better see the spine through other modalities than direct visualization.
Thank you. What types of spinal surgery are done with the technologies that you described today? Is it only fusions or is it other types as well?
Yeah, that's a great question. So predominantly fusions. I think that there's lots of talk and lots of work being done presently to do decompressions robotically or with navigation, or even using AI to predict where you need to do the decompression to get the best outcome. And so I think for sure that's coming, but currently most applications are for fusions.
Thank you. Does health insurance cover surgeries that involve AI?
Yes. So there are codes for it. And for almost all my spine surgeries, I'm getting prior authorization through those insurance companies, and the codes are for computer assisted surgery, and so that the codes are out there and they're prior authed and approved.
Thank you. Does using this technology allow you to make custom hardware, or how does it interact with the hardware that you're using?
That's a great question. So most of the hardware is interchangeable with most of those devices for navigation. Some of the robotics and navigation and augmented reality are a closed system, so you have to use a certain vendor's hardware. But most of the stuff, the fluoro and O-arm and planeform radiographs, of course, any hardware. There's a whole nother discussion about customizable implants, and I would love to talk about that. I think the customizable rods and or cages that go on the inner bodies, for sure is a very hot topic right now. The pedicle screws are very modular, is what I'm going to say. And so they come in different diameters and lengths. And so almost always for all my patients, there is a ton of customization that goes into those pedicle screws. The beauty of doing the AI or the robotic spine surgeries is that I get to plan all those screws before we even roll back in the operating room. And so once those screws are planned, those screws are assembled to the patient's anatomy, and then we're putting them in, quicker than assembling them on the back table. So that's a great question.
Thank you. If somebody's spine surgeon doesn't use this technology that you've described, should they get a second opinion?
Well, I think that there is still lots of surgery being done across the country that is done in an open, very traditional approach. And I think that you have to be careful when you switch over to this technology. It's like you want to make sure you're trained and appropriately well-versed in not only how to use it, but the complications that are associated with it. And so I think that surgeons that are still using fluoroscopically placed pedicle screws, or even an open approach, if they are older surgeons and have trained on it and do it well, I think that the outcomes can still be good. I personally think that the minimally invasive spine surgery applied appropriately is better for the patients, and there's definitely some literature to support that.
Thank you so much, Dr. Herzog. We are out of time for questions. We did not have a chance to get to your question live. Please put it in the Facebook comments and we will answer it there. Dr. Herzog, would you like to close?
Thank you so much for letting me speak for a minute there. I always enjoy these. Please reach out to me if you have those questions. I will get back to you, and everybody have a great Wednesday night.